I, Harshita Yakkala, Scientific Officer at Bionest, on behalf of Aspire Bionest and School of Life Sciences, take privilege to introduce you all to our today's guest, Dr. Sairam Atluri. Dr. Sairam Atluri is a leading expert in interventional and regenerative medicine and a pioneer of stem cell therapy in the US with over 32 years of experience in the field of medicine. Through his focus on pain management, he has created Stem Cures, an FDA-compliant outpatient stem cell procedure that uses patients' own stem cells to treat pain. Dr. Atluri is a pioneer in this treatment and is the only local physician who is certified in regenerative medicine by the American Society of Interventional Pain Physicians, ASIPP. For his pioneering work, he was awarded the prestigious Raj and Manchkanti Award of Excellence by ASIPP. He was chosen as the top pain doctor in the US by the prestigious Becker's Review. He is the co-author of Regenerative Medicine Guidelines put forth by ASIPP for the safe and responsible use of stem cells to treat pain. He has published 38 articles in peer-reviewed journals regarding pain management, and the number is still increasing. Dr. Atluri is one of the very few who is double board certified in pain management by ASIPP and World Institute of Pain. Sir, it's an honor to have you here with us today. I request you to share your immense knowledge and thoughts with us and inspire us. Please join me in welcoming Dr. Sairam Atluri.
Thank you for that generous introduction. I want to start with my favorite quote. This is from Ronald Reagan, who said, "Stem cell research can revolutionize medicine more than anything else since antibiotics." Maybe vaccine is another exception, but and this is what we're seeing in clinical practice. I've been doing stem cell therapy for about 5.5 years, mostly to treat back and joint pains, and stem cells have really been a game changer. So this is the outline. I'll be talking about different kinds of stem cells, the evidence behind the stem cells, mechanism of action, complications, challenges that we face, and the future. So not all stem cells are the same. So there are two kinds of, broadly speaking, two kinds of stem cells. Hemopoietic stem cells. These are the stem cells that generate our blood cells like RBC, WBC, platelets, etc. And they do not have any immunomodulatory function, and they do not have any regenerative properties. So these are the stem cells that we are not interested in. This is what we're interested in, is the mesenchymal stem cells, or commonly known as MSCs, and they have regenerative and healing properties. So if you look at mesenchymal stem cells, there are many kinds: embryonic, fetal, induced pluripotent, and adult stem cells. So embryonic stem cells we cannot use because of ethical issues, and they also are tumorigenic, which means they cause tumors. Same thing with fetal stem cells. And induced pluripotent stem cells don't have any ethical issues, but they're also tumorigenic. So we're stuck with adult stem cells. So different kinds of adult stem cells, let's look into that. So you can get it from the bone marrow, fat, and perinatal tissues like umbilical cord and placenta. Every tissue in our body has mesenchymal stem cells, but these are the easily accessible sources to use in patients. So why umbilical cord MSCs are one of the best to use in patients is because it's a plentiful source. Umbilical cord is considered a medical waste. They're highly proliferative, and this is a big advantage for us because once we get the cells out of the cord, we have to multiply them, multiple passages, because we need a lot of cells to treat patients. The typical dose is anywhere from 70 to 100 million cells per dose. And if you over multiply them, or if you get cells which are not very proliferative, during culture they end up having karyotypic and genetic aberrations. So we want a cell which is very proliferative. And they don't have any epigenetic changes like the bone marrow or adipose stem cells. And they're also day zero cells, the fresh cells. And another important thing about adult stem cells, all adult stem cells, bone marrow, fat, or perinatal stem cells, is that there is no immune rejection because there are very few MHC1 receptors, no MHC2 receptors, and no co-stimulatory factors. So this is nice because you can have a universal donor, a donor you can inject in anybody, and there's no immune rejection. And adult stem cells has been established, it's an established fact that they're not tumorigenic based on multiple studies. So let's look at the evidence. Do they even work clinically? COVID-19 has made a difference for stem cell in terms of regulations. The regulatory bodies are looking at stem cells more favorably after COVID. So FDA even gave emergency use authorization to use stem cells in patients who are critically ill and not responding to traditional treatments. So in March of 2020, before FDA gave authorization to use stem cells, we published an article, this was before COVID hit US, saying that there is a role for stem cells in patients who are not responding to traditional treatments, who are suffering from COVID. And this article was the first article in the US about stem cells and COVID, and the second article in the world about stem cells and COVID. And we're very proud to report that this article was cited in 204 other medical articles. So since our article was published, there have been 10 controlled trials and multiple case series regarding the use of COVID, regarding the use of MSCs in serious COVID patients who were dying. And this is the list of all the trials for your references if you want to look up. So these controlled trials treated severe to critically ill patients, and they're from different countries, US, China, Germany, and Indonesia. And what they reported was that stem cells decrease mortality, decrease hospital stay, and they immunomodulate the cytokine storm. They do organ regeneration, especially the lung. There were no complications from stem cells. And look at this slide carefully, because there is no drug as of today which can do this. And this is a picture from one of the studies. You can see the COVID ARDS lung with the ground glass appearance in the X-ray, and after stem cells, how it's all cleared up. Now, low back pain is another condition which we looked into. It's the most expensive medical condition in the US. And it's a very challenging condition because traditional therapies generally have failed in treating chronic low back pain. So this is the first study where they injected bone marrow stem cells into the lumbar discs to treat back pain. So they took 26 patients with severe low back pain who were supposed to get lumbar fusion surgery. And they injected the bone marrow stem cells into the discs, and they reported 70% of these patients had significant pain relief. And this is an important point, and the pain relief lasted even after 5 years. 40% of these patients showed regeneration on the MRI when they scanned them a year later. And also importantly, there were no complications. And 76% of these patients avoided fusion. So we have really good anecdotal experience in treating back pain and joint pains with stem cells. So we decided to do a trial, which was published about 2 months ago. So we did a prospective control trial. This is the first prospective control trial ever being done in the world regarding stem cells and low back pain, and also the largest trial, by the way. So we took patients who had severe low back pain and injected stem cells. And these patients had severe changes on the MRI. We did not carefully screen the patients. So divided them into 2 groups. The first group had conventional therapy, which is mostly injection therapies and medical therapy. 40 patients in that group. And the second group injected stem cells into the disc, facet joints, and on the nerves. And 40 patients in that group too. We followed them up for a year, and we assessed their pain and function scores. I don't know if you can appreciate it. This is our procedure pictures. The disc is completely collapsed at this level, and you can barely see the disc at this level. So just to give you an idea of what kind of patients we were dealing with. So this is what we found. Within 1 month, the pain in the stem cell group fell dramatically. This is the control group. And then the pain relief was maintained even after 12 years. This was statistically significant. And same thing happened with leg pain. Leg pain is from nerve compression in the spine. We had similar results with leg pain, significant difference after a year between the 2 groups. And after 12 months, almost 70% of patients in the stem cell group got significant pain relief and significant improvement in their function scores compared to only 8% in the control group. The other condition is knee pain. This is a busy slide, but I just want, these are all the studies that were done. I want you to pay attention to this pain relief. Every study showed positive pain relief. These are all bone marrow stem cells. And none of these studies had any complications. This is another important study for knee pain. This is a study from France. Dr. Hernigo, who's actually considered a godfather of stem cells, especially for bone marrow, he took patients who had bilateral knee pain. One knee he injected stem cells, and the other knee they did total knee replacement. And he compared the results between the 2 groups. And they followed the patient for 12 years. And they found that pain relief was similar in both the groups. And this pain relief with 1 injection lasted for 12 years. There were more complications in the surgery group and very few complications in the stem cell group. So he did another study, same in the knee, and this time he followed them for 15 years. So even after 15 years, the pain did not come back. So based on the evidence that exists in the literature right now, there is a potential that stem cells can replace joint replacements and fusion. So this is a lumbar fusion surgery, extensive incision. They cut the bones, put rods and screws. This is how fusion is done, and this is how stem cell therapy is done. I just want to show you the difference in terms of invasiveness. And same thing with the knee replacement. This is how the knee replacement surgery looks like, and this is one of our patients' picture where stem cell therapy was done. The other condition I wanted to talk to you about was diabetes. So this is Frederick Banting, who discovered insulin, and he got a Nobel Prize for that almost 100 years ago. And this is his statement when he discovered insulin. Insulin is a treatment for diabetes, not a cure. So when you have high blood sugar from diabetes, it is a symptom. The problem is either the insulin producing cells are dysfunctional or the receptors, the insulin receptors are dysfunctional. So that's why the sugar goes up, and when the blood sugar is controlled well with insulin and other medications, does it prevent complications? Because you're not treating the problem, you're just taking care of the symptoms. So this group in France, in 2017, looked at all the literature for diabetic treatments, and they wanted to answer this question. If you do a tight glucose control with medications and insulin, will they prevent diabetic complications? Because end of the day, that's what we treat diabetes for, is to avoid complications. And this is what they found. When you have a tight glycemic control, it does not reduce any cardiovascular mortality. It does not decrease the risk of stroke. It does not decrease the risk of peripheral vascular disease or amputation, and does not decrease the risk of heart failure. And they say it may even increase slightly the risk of heart failure. So controlling glucose is not enough in treating diabetes, but that's what's been done for over 100 years. So the question is stem cell a potential treatment? So these are all the studies. There are 3 studies for diabetes, and all of them have shown that stem cells can increase the insulin dose, decrease glucose, decrease hemoglobin A1C, which tracks blood glucose. And this is important, it increases C-peptide. So every time insulin is released into your body, it releases C-peptide as a byproduct. So it's a surrogate marker for how much insulin is released. So, and again, pay attention to this slide. There is no drug currently that does this. Now finally, the medical fraternity can dream about curing diabetes. Liver failure. So the 23 trials which have been published, mostly cirrhosis of the liver. Out of 23, there were only 3 trials which did not show positive results. And positive outcomes were seen in these liver failure patients regardless of the etiology of the liver disease. And there were no complications in any of these studies. This is another busy slide showing all the positive results here, improvement in liver function. So it's a broad spectrum therapy. That's the beauty of stem cells. There's so many conditions we can use with this technology. So this group looked at all the data that's available in the literature and did meta-analysis and systemic review for stroke and stem cells. And what they reported was that it can improve neurological deficits and activities of daily living in patients with ischemic stroke. Another group looked at stem cells and heart disease and congestive heart failure. And they reported that it can be effective and warrants further research. Like I was telling before, it's a broad spectrum therapy. These are all the different specialties the clinical trials are going on right now. And currently, if you go to clinicaltrials.gov, there are 8,500 stem cell trials which are going on just with MSCs. So if you summarize the evidence, there's extensive animal data showing that it's very effective. There's preliminary clinical data showing that it works. And more importantly, there's a lot of animal and clinical data showing that it is safe. And we can treat multiple conditions. So mechanism of action, how do they do their magic? So if you want to treat spine or joint pains, you have to inject that into the joints. So this is what happens in our joints. Every day, there are these inflammatory proteins or catabolic proteins like IL-1, MMPs, and TNF, which are attacking the joint and trying to destroy the joint. At the same time, we have these anti-inflammatory proteins. This big list here, IRAP, PAMP, and TGF. They are repairing the joint and having an anabolic response. So there's always this constant battle between these two proteins in the joints. And fortunately for most of us, the good proteins are winning the war, and that's why most of us don't have any pain. But when the bad proteins or the inflammatory proteins take over, that's when inflammation sets in, and then you have pain. And this is what stem cells do when you inject stem cells into the joints. These anti-inflammatory proteins, and what they do is they decrease inflammation, decrease pain, decrease scarring, and they stimulate the native stem cells, which are usually quiescent, but they stimulate them and activate them to regenerate the joint. So from a catabolic microenvironment, it becomes an anabolic microenvironment. And this is how it works. So stem cells, they secrete a lot of these good proteins. That's why they're commonly called as a secretome. They have all these proteins which causes, takes care of inflammation, they're immunomodulatory and mitotic with the cell regeneration, decrease scarring. So the anabolic state is restored from a catabolic state. This is another interesting mechanism of action. Stem cells form these tunneling nanotubes, and through these tubes, they transfer mitochondria and microRNA to the sick cell, which rejuvenates the sick cell. And as you know, mitochondria are the cell batteries. This is a nice electronic microscope picture of the tunneling nanotube from the stem cell to the sick cell or dying cell. So if you want to treat systemic diseases like diabetes, liver failure, heart failure, stroke, you have to inject them intravenously. And what's interesting is, once you inject these cells into the bloodstream, they're gone from your body or the patient's body after 10 to 14 days. But the effects linger, the positive effects linger, because they modify the immune cells. How they do it is the macrophages, the monocytes, and the dendritic cells, they engulf these stem cells and they change, because these cells are very plastic. Their phenotype changes depending on what your body needs. So these immune cells, M1, T helper cell 1, and dendritic cell 1, they are very inflammatory and catabolic, and they secrete these catabolic proteins. With the influence of stem cells, the same cell, M1 becomes M2, TH1 becomes TH2, DC1 becomes DC2. Now these cells secrete anabolic proteins, and they're very anti-inflammatory. So that's how it changes the tissue microenvironment and enhances repair and regeneration. So these modified stem cells then enter into the circulation, and they go to the diseased organs and do their repair there. And I just wanted to show you, stem cells have positive effects on every immune cell, including T cells, neutrophils, B cells, macrophages, dendritic cells, and natural killer cells. Exosomes is another mechanism of action. It's a hot topic in the last decade. So the exosomes are also extracellular vesicles. So each cell communicates with another through exosomes. So the stem cell, they're created within the endoplasmic reticulum, and they're released into the extracellular matrix, and they're taken up by the native cell or the sick cell. these exosomes have a lot of mRNA, and once it's taken up by the sick cell, they start translating these beneficial proteins that I talked about, and again, that causes regeneration. So they also modify the immune cells, and like I said, they enter disease cells and repair them. And this is the most fascinating part of mechanism of action, is you're actually infusing intelligence. So when you infuse stem cells, they not only identify what's wrong with the organ, and they secrete these custom proteins which are required to repair their organ. I mean, we've made so many advances as humans, but we still haven't created a cell. It's so complex. So this is the beauty of nature, and we're just taking advantage and harnessing the power of nature by using stem cells. So let's talk about complications. So we published this review article in August of 2020, and we looked at stem cell therapy to treat strokes, lung failure, heart failure, kidney failure, and liver failure. There were about 110 studies, and we looked at complications. And I'm very happy to report there were no complications from these 110 studies. And another group from Canada did their own analysis, and they reported the same thing, that stem cells are very safe. This is another group, same conclusions. So if stem cells are done appropriately by the right people, the complications is minimal or negligible. But we are seeing disasters. And this is because it's being done mostly at private clinics, not following regulations and guidelines, and that is creating all these problems. So this is a report where 3 patients were blinded after stem cell therapy, and there were 2 other reports which surfaced later about blindness from stem cell therapy. This is another report where there were serious infections when they used stem cells. And this is because when FDA inspected their lab, there was blatant disregard for sterility. And even the patients who got blinded was not because of stem cells, but the procedure was done by providers who were not specialists in the eye. The Pew Research Group analyzed the stem cell data over a period of 16 years from 2004 to 2020, and they found 360 complications from stem cells, 20 deaths. And what they reported was 80% of these clinics were run and stem cell therapy was done who were not qualified to do this therapy. So in conclusion, regarding safety, stem cells is an incredibly safe procedure or treatment, but we have to use the right stem cell, the right manufacturing process, by the right physician who's properly qualified, right indication, and in the right patient. So I want to talk a little bit about the challenges. The regulatory approval is the biggest challenge that we face right now, and rightfully so. They're very skeptical. It's a new treatment, and they're seeing not a lot, but complications. It's difficult to adopt. So that is the biggest challenge right now. And it's not accepted by mainstream yet because it's so new and nascent. So the future direction. So it'll be nice if all of us come together, the manufacturers, and standardize cell characterization, decrease the cost of production, and perform well-designed controlled randomized trials, and hope that the regulatory burden is not onerous. It's required, but hope they work with us and make it easy. So we started this company, Tulsi Therapeutics. We have two goals in mind. One is to bring the latest technology from the US and create a premium stem cell, high quality stem cell, not just in India, but globally. And our second goal is to make this manufacturing process affordable so we can help many patients who are like common man. So we named our company after my grandma, Lakshmi Tulsamma. She is from a very tiny village, was dirt poor, and was widowed at a very early, very young age. And after working tirelessly, independently, just by herself, she raised my father and made him a dentist. And this is my dad, Dr. A.S. Narayana, who's an eminent dentist in Hyderabad. He was also the professor at Government Dental College. But I'm most proud of about him because he dedicated his life to help the poor and needy. He's conducted thousands of medical camps and dental camps in the remote villages where there was no health access. He was also very active in Nalgonda district when fluorosis was a big deal. He supplied them with devices to remove fluoride from the water. A lot of these patients had musculoskeletal deformities and spinal deformities. He brought them to Nizam's hospital, got surgeries done on them, and also a lot of free cataract surgeries giving vision to many of these patients. But because of his efforts and social service, he was honored with Padma Shri. This is the picture. So very proud of him. So he's also a major investor in this company. I really would like to thank the management of BioNest for when we approached them for incubator space. They moved very fast, they were very helpful, and really appreciate their help. And I was very lucky to find Dr. Ravi here, who's a very good cell culture specialist, and I could not have done this without him. So we want to do clinical trials, and this is in acute liver failure, juvenile diabetes, and autoimmune arthritis. This is going to be a long and challenging road and difficult road for us, so we need all your blessings and best wishes. So ultimately, I really hope that this field advances, the more companies coming in and promote this therapy, and it'll be great sooner than later if we use cells and not pills to treat many of these incurable diseases. Stem cell therapy has a potential to change medicine and, more importantly, to change lives. Thank you so much. Yes.
So, I have a general question related to using this stem cell therapy to treat neurodegenerative disease. So, in there, like just restoring the number is not really good enough, right? So, if you want to use a stem cells to treat neurodegenerative diseases, where just like mere restoring the number may not be that important, because neurons has to make a lot of connections, right? So, restoring the connections is a bigger game there. So, where exactly do you see like a stem cell therapy in treating neurological disorders?
I mean, it depends on what degenerative condition, right? If it's the brain or if it's the spinal cord. these cells don't become neurons. That's a proven fact. They don't home like we thought initially. Like if someone has spinal cord injury, inject them intravenously or intrathecally, they go into the cord injury, and initially we thought they'll become cord cells and make those connections that you're talking about. None of that is happening. But what's happening is they secrete, like I was showing the secretome, they secrete a lot of growth factors, and that's how they repair by stimulating the native stem cells. So in conditions like that, you need multiple doses. One dose is not going to be enough over a period of time. Hope that answers your question.
Can
I think,
Yeah.
your initial slides have shown that you have done work on the back pain.
Yes.
So, but your company doesn't show that you have any plans for the active treatment.
Great question. In the US, only bone marrow stem cells are allowed. You can't use any other cells. So that's our expertise there. But there are so many other conditions where now we want to inject intravenously umbilical cord cells, and then you can actually inject them into the disc too. But we want to go after serious life-saving conditions first, eventually into back pain also, and also joints.
see, here one. Yeah. See, underlying pathology is very critical. Even you have giving stem cells for the repair. Now, how you are managing the pathological signaling or other factors so that it helps, because injecting everywhere MSCs may not help. It depends upon, as you have shown, pro-inflammatory and anti-inflammatory. So like when in the clinically, are you formulating these MSCs in such a way that they fit for that condition?
You asked a great question. You bring up a great point. The beauty of this is you should not touch the cell. Don't modify it. Don't mess with nature. It knows what it's doing. So people have tried that. They've tried to make, like for example, stimulate that with interferon gamma, and so it produces this anti-inflammatory proteins, and then inject. It didn't work, and plus there are complications.
The host site.
Yeah, host site. I strongly believe, do not mess with nature. It knows what it's doing. Just inject the stem cells as they are.
Yeah, I have a question, Dr. Sairam. Yeah, it's a wonderful talk, and we have opened up a lot of discussion in the various pathological paradigms. And I wish you great success in your future. I have a couple of questions. One is, it looks like that you are making a symptomatic treatment. So, because in one of the slides you showed only disc regeneration is one patient, whereas others are not. So, this is my first question. Second question is,
You can answer that one at a time, please. So, 40% of patients had disc regeneration, only 40. And even in our study, only 40% had disc regeneration. And that too, I had to review with the radiologist. There's increase in T2 signal, there's increased water content. It's very subtle, even in those 40% that we saw. So it's not regenerating the disc, but the pain is gone, the function is improved. So it just tells us that back pain is not a mechanical model, it's more an inflammatory model. And the pain is gone for a long time. So there is some regeneration that we're not able to see.
actually that's what really surprised. 12 years and 15 years is a too long time that once a dose is given.
Yeah, but this was injected into the bones, not the joint. So if you inject the joints and the bones, and that's what I'm seeing even in our clinical results, when you do that, it's a one-time therapy. Like very rarely the patient comes back. It's been 5.5 years that I've been doing. It's very rare the pain comes back, unless they re-injure. That's a different story.
Yeah, my second question is that you prefer to inject at the site of injury or inflammation. but that's a bad site for the survival of the cells. For example, if you take in the case of the stroke patient, we don't prefer to inject at the core but penumbra region, so or in the circulation. So why do you prefer? Because cells might die even in the necrotic region or the inflammatory regions. So why can't you prefer that? As you know, the homing is there always.
It's a good point. When you inject, like the heart, for example, congestive heart failure in a dead myocardium, studies have shown that they don't home, they don't engraft, they don't duplicate, because that area where you inject the cells, it takes a long time for it to get vascularized, especially in the dead necrotic area. So that's the nice thing is it's very invasive procedure to put it in the brain where there's injury, in the heart where there's injury. So we don't have to do that. And you're absolutely right. They don't survive, they die, and they don't do anything. So that's why intravenous is better. And I didn't mention this, but when you inject it intravenously, these cells end up in the spleen and the lymph nodes. And there they change the immune cells, the macrophages, monocytes, dendritic cells. They become pro-inflammatory, from pro they become anti-inflammatory. Then they're released into the bloodstream. Those home to the diseased organ. And that's where they do the reparative mechanism by secreting these factors, not the stem cells.
Yeah, that's true. Yeah, that's why actually we did with carotid rather than vascular vein or something. So which is near to the carotid artery that goes straight near to the site of injury in the case of the stroke.
So a great point. If you inject in the carotid artery or into the coronary artery, after 1 hour, only 3% of the cells are in the organ. They're washed away. So there's no point in injecting into the carotid artery. Plus, the other problem why I don't like arterial injections is the size of the stem cell is usually around 20 microns. It's a large cell, and the capillary size is only 7 microns. So there have been some reports of occlusion. And that's the beauty of it, right? You just simplify it, make it safer by giving it intravenously, because there's no need to give it intra-arterially. There's no advantage. And plus, there's a disadvantage of occlusion.
To add to the same the point that was raised, the survival of the stem cells, especially in the back where the discs are, the nucleus pulposus cells, the condition is hypoxic there. And these cells need the oxygen to proliferate and regenerate. So probably that's the reason why the survival rate is only 40%, what you're saying. And also the pain is gone only because of the release of those anti-inflammatory kind of compound. Probably the pain is gone, but the regeneration of those stem cells probably the condition itself is hypoxic.
Good point. It's not only hypoxic, it's also acidotic.
Yep.
It's a very, very harsh microenvironment. And also hypoglycemic. You know, it has no nutrition, it's all coming from diffusion. It's a very bad environment. But there was one study, this was from Sweden, where they injected bone marrow stem cells, and patients who had surgery, when they did the discectomy, they looked at the tissue. And this is fascinating. And after an average of 8 months, they found that not only the cells survived, they proliferated, and they secreted extracellular matrix and collagen. So they are surviving in that harsh environment. But that's an avascular tissue, so they can't go anywhere. But if you inject into the coronaries or the carotid, it's a washout. But it's a great point what you raised, but that's not what has been shown in the clinical studies. And the 40% regeneration, I'm sure there is a microscopic regeneration going on. We just can't see it with the MRI.
Doctor,
Sorry.
Sorry, I know you feel so. Good.
Thank you.
Yeah.
It was a nice and comprehensive presentation. I have maybe two questions. First, you said you want to bring your technology from the US to India. So Tulsi is your India incorporation.
Yes.
Right? And then another point also that you said, you do not believe in formulating and you just want to present clinically, I mean, in the natural format, right? I mean, of the stem cells. So what technology are you referring to? I'm sure it must be your proprietary. And again, must be to do with bone marrow, because you said in the US you have only permissions to handle bone marrow. Is it for just autologous application, or you're also looking for allogenic application through your Tulsi therapeutics?
So what we want to do is, first of all, the cell will be a perinatal cell. It's not going to be bone marrow. It's not going to be adipose. We truly believe that's the best stem cell. And it's going to be allogenic, and it is for systemic application. In India too, you cannot use it. It's illegal.
True.
But we want to go through those trial process and get the drug approval. The technology is, we're going to get bioreactors and also make it a xeno-free process, which nobody has it right now. I don't think even in the US there's a company which is doing xeno-free process. So I hope that answers your question.
Yeah, sure. Yes, that's right. And then another quick continuation of this. Even in India, I mean, yes, the regulations are there. So your interest to come about solutions for those three indications, the last slide of yours. Again, I mean, it can't be one solution to address all the three, right? I mean, that's not what you're thinking. Am I right?
No, it's one cell.
One formulation.
One formulation.
For all the three.
Everything.
I'm not sure, but in India, I don't think so. They would even consider one application to treat 3 or 4 different kinds of indications.
One cell, multiple studies. Each indication has its phase 1, phase 2, phase 3 study. So yeah, it's not one cell and using that cell to treat all conditions, but we're going to do trials, but with that one cell.
Thank you.
It's a good presentation. Many of these autoimmune disorders like arthritis and many skin disorders, they're being treated with steroidal drugs. And the effects are only transitory. You need to continuously treat. So using these kind of stem cells, whether that there will be long-lasting effects like conditions like arthritis or psoriasis and things like that. So that's...
So if you look at acute conditions like COVID, when patients are dying and you're treating acute conditions, 1 or 2 or 3 doses is enough. They recover, it's over. But when looking at chronic conditions like you're mentioning psoriasis and other autoimmune disease, one treatment generally lasts, and this is all preliminary information, right? Lasts 6 months to a year or 9 months. So my gut feeling is there hasn't been enough studies on this, but my gut feeling is they would need these stem cells every 6 months or 9 months for chronic conditions. And I'm hoping that you start every 6 months, then you need to do every 12 months or every 18 months as you're treating them. I'm hoping that will happen so they don't need as many. But the nice thing is it's safe, even multiple doses.
Even that also very beneficial in the sense that steroids you need to use continuously every day.
And also they have a lot of side effects, steroids.
Thank you for a very informative talk. I have two questions. One, I was wondering whether the age of the subject and the presence of other morbidities, have any of the studies looked at it?
Great question, yes. As you age, both the function and the number of stem cells comes down, and it's dramatic. And there are also the second problem with aging and stem cells and using patients' own stem cells is the epigenetic changes that happen in the stem cells. But in bone marrow, when we use bone marrow, because we're restricted to the bone marrow in the US and even in India, it still works. We're seeing results. But is it the best cell? No. But we have to work with what we have. So that's why we are going into perinatal tissues to get hopefully the best stem cell.
So the dosage and everything will differ based on the age and presence of other morbidities?
Yes, that's what I'm talking about, epigenetic changes, because the genome of the stem cell is different if someone has diabetes or hypertension. It does make a difference, no question about that.
And I was wondering, since you mentioned that you're not making any changes in the cells, you're not formulating it, so what about off-target effect? Like, for example, if your aim is knee pain, but have you looked at off-target effects?
What do you mean, like side effects? Oh, I see what you're saying. In helping in other, if the patient has other issues, when you inject the knee, will it help that? I think we're seeing the opposite. If you inject the knee, most of them stay in the knee, they die in the knee. I mean, it's not exposed to the systemic circulation and the immune cells. But if you inject intravenously, when we treated some COVID patients, interestingly, their arthritis got better, to your point. I had one patient who had neuropathic hand pain from electrocution when he was 20 years old. Had pain for, he's 80 now, and that pain was dramatically better. So it is having offside effects, but good ones, not bad ones.
Thank you.
Nice clinical presentation, the application of stem cell therapy. My point number one is, how about the source? Let's say you isolate your stem cell from source A, patient, or human A versus human B. Do you see any challenges in terms of reproducibility or characterization at a very, very minute level, not at a macro level?
A stem cell is a stem cell, right? Bottom line is it does what it's supposed to do.
Coming with the whole kind of when you are isolating it.
So let's say we want to get from the placenta or the umbilical cord, right? The cell is the same, right? And our process, it's a great question. Our process is the same. It's not going to change. So what we have to do is characterize each batch before it's released, saying that it has these surface markers, the viability is this much, these are the growth factors it produces. So that's our consistency.
So that is the criteria normally set by FDA or eventually Indian agencies that, from source A to B, you should have this much.
Exactly. And we have to do that. The onus is on us to prove that our process and our source, the cell is the same.
Yeah, in addition, people say age, absence of infectious diseases, AIDS, TB, etc. in the donor from whom we are collecting these samples.
Right.
The first exclusion criteria, exclude this, pick it up. And then you do your characterization.
Absolutely, right.
Get the uniformity and then take it up.
Absolutely.
First filtration, donor selection. Second, your character.
Correct.
So my second point is in the context of mechanistic, understanding. I've been following in the context of metabolic disorders of diabetes. Of course, the interest is somehow we need to grow up the beta insulin-producing cells, and this is one way of pushing it. Of course, I also noticed a lot of interest in using some biological cocktail or maybe eventually some chemical cocktail also. This is still, I think, more of the work in progress. In your case, you're using, let's say, stem cells directly. And could you just shed a light on the mechanistic direction, like what's really happening in the system? You know, you injected the stem cells, and of course you showed about that pipeline, nano kind of tube for mitochondria, which is also another way of rejuvenating your mitochondria. But some other way, like, could you shed some light on what could happen in the diabetes? So that could have a lot of interest.
So the two issues. One is production of insulin from islets of pancreas. Second thing is this decreased production, right? One problem. Second problem is the receptors are not responding to insulin. That's the two issues. So what is happening is, and this is based on animal science, right? What we find is the stem cells are taken up by the immune cells. The stem cells are gone from the body, which is actually good news. You don't want the donor cells hanging out, right? And they alter the immune cells of the host. And it is an autoimmune problem. So they're immunomodulator, they're known for that. So they're modulating the immune system, almost kind of resetting the immune system, right? And these cells produce these regenerative proteins at the islets of pancreas, Langerhans, and they also stimulate the native stem cells. So it's very clear when there is regeneration, that regeneration is not causing from the DNA. It's not the donor DNA. It's the host DNA which is there in those regenerative cells. So the native stem cells are creating this regeneration.
So somehow we are kicking in our internal system,
right,
which is then producing the
exactly.